using illness trajectories, including that of multimorbidity, to inform person-centred advanced care planning. Most people used to die following one of three illness trajectories: acute decline, typically progressive cancer; intermittent decline, typically heart failure or COPD; or gradual decline over many years, typically in old age or dementia. However, many people now live older and die with multiple conditions, and a multimorbidity trajectory can also be visualised. This physical trajectory of decline may have many sudden dips due to instance, accidents, pneumonia, or hospital admissions. But apart from the progressive physical decline, people have also predictable psychological, social, and existential trajectories. Dying is a four-dimensional process. We have previously described in people with progressive cancer that their social functioning often declines alongside physical deterioration. But their psychological and spiritual well-being tend to fall at four key times: around diagnosis, at discharge following treatment, at recurrence, and at terminal decline. In contrast, people with declining organ function, their social and psychological well-being may parallel their physical functioning, while their spiritual distress fluctuates more. And in people with advanced frailty or dementia, their psychological and spiritual well-being may be affected by an acute physical illness or changes in social circumstances. So in older people with multimorbidity, how might their psychological trajectory progress? There may be anxiety or depression associated with a physical illness, or worry about getting dementia or being admitted to a care home. Social concerns may include not seeing friends, especially when acutely unwell, or not getting out, or feeling they are a burden to their relatives. Existentially, well-being may suffer if someone is unable to do what they used to do, and a feeling of loss of control may make someone lose their sense of meaning and purpose in life, causing agitation and distress. So to adopt an individualised approach in people with one or more progressive illnesses, we propose a four-stage care cycle. 1. Early identification. 2. Multidimensional assessment. And 3. Care planning. And 4. Coordination and communication with all people involved. So understanding these frequent concerns and likely patterns allow us to identify early when a patient might benefit from more comprehensive care. This allows us to detect people with progressive illness early during the so-called first transition and start advanced care planning or early before reaching the second transition of imminently dying. Then we must an individual assessment to 1. Check in what dimensions there may be problems or difficulties, and 2. Perform a situational diagnosis, that is, at what stage of the trajectory is the person at, A, B to G. Then it is time to anticipate the patient's concerns about how the illness may progress and help the patient, clinician and family plan together, often in the face of great uncertainty. Then we must communicate a care summary to everyone the patient or carer may contact for urgent or emergency care. This four-stage cycle is an essential part of personalising care. Identify people with deteriorating health. Use a simple, validated tool. One based on burden of illness and clinical indicators is better than based on prognosis. Assessment can also be aided by various primary care, palliative care or geriatric tools. Planning and decision-making can use a number of tested formats. Vocabulary should be acceptable to patients to avoid stigma. And communication of the care plan across all settings is very valuable and best done routinely and electronically if possible. A take-home message then is that in people with any progressive illness trajectory, a four-stage cycle to enhance integrated care should be triggered and reviewed. We can do this in the community and in hospitals. If patients have discussions and acute treatment and planning based on their likely multidimensional illness trajectory, their quality of living and dying will improve. This can reduce distress while promoting realistic understanding of normal aging.